Hi, and welcome to part 3 of the evidence-based treatment recommendations. We're going to start first with evidence-based treatment recommendations for ADHD. So this is not yet specific to intellectual disabilities and ADHD, that unique combination, that unique group, but rather evidence-based treatment recommendations for ADHD broadly. All right, so when we talk about evidence-based treatments for ADHD, broadly there are three classes of what we would say are evidence-based treatments. The first are what we call behavior modification studies. Behavior modification studies are the types of studies where we either modify the environment, modify the way someone is reacting or engaging with a person, and/or we do skills teaching to the person in order to empower them to be able to behave differently compared to how they had been behaving. So I know that was a big mouthful, but really when I say behavior modification studies, what we mean is maybe we explicitly teach a skill of instead of interrupting, someone comes up and says, "Excuse me, can I ask a question?" That might sound minor, but the type of reaction that a person gets when they've interrupted over and over and over again is very different than the type of reaction they get when they come up and they say, "Hey, excuse me, can I ask a question?" That reaction that I'm making reference to, sometimes we work with the caregivers or the adult in the life of the child as opposed to the child themselves. So teaching a caregiver or someone else how to react differently. So to give more strategic attention to certain behaviors and intentionally, withdraw from undesirable behaviors. Or we might change the environment so as to change the likelihood of a certain response happening. Those are all examples of behavior modification studies. And there have been hundreds of these studies at this point that have shown that this has a really, really impactful outcome on folks with ADHD. The second class of studies are CNS or central nervous system stimulant medication trials. There have been more studies of CNS stimulant medication, in part because these types of studies are a lot shorter in length. The impact of medication is seen more readily as opposed to behavior modification, where you kind of have to build up some skills. And so there have been more studies pretty uniformly that shows that they have an impact on a person's functioning. Now, at this point, folks often ask me, what about non-stimulant medications? And yes, absolutely, we should include those. There are comparatively far fewer treatment outcome studies. They exist, but there are far fewer than there are for CNS stimulant medications. And then thirdly is the combination of the two. So the combination of behavior modification and stimulant medication studies. There have been far fewer of non-stimulants in BMOD than there have been of stimulants in BMOD. When we look across these three modalities of treatment, there are a couple things that I think are really important to note. One, looking broadly across, we see moderate to really large effect sizes across these treatments. So what that's telling us is that these treatments work, and they work in not only a statistically meaningful way, but also in a noticeable way, in a clinically relevant way. We're seeing changes in outcomes because of both of these types of treatments. But there are some important caveats to note. In the title above, you'll see that the word short term is underlined. That's because the overwhelming majority of these studies have been short-term treatment studies. There have been very, very few long-term treatment studies for ADHD, and so we have to be far more cautious in what we say works for folks long-term. The other caveat that I want to make sure I'm noting is that the great majority of these studies have also been done with children. There are far fewer studies on adolescents and adults. So when we are talking about long-term treatments for adults, we have to be extremely cautious, borderline saying, we don't really know long-term what evidence-based treatments are, but we do know some about what short-term evidence-based treatments are. So we just want to be appropriately, matching what recommendations we're giving to folks. All right, so I want to summarize this really large literature in the best way that I can for you by first starting to talk about what some of the beneficial effects of behavioral treatments are. And there are a number. One of the first ones, and ones that can be really important both to the adults in the life of the child, but also to the child themselves, is that we see improved functioning at home. And in terms of the primary outcomes that we see, we tend to see improved compliance and more positive parent ratings after doing a behavioral intervention in the home. We see improved functioning in school. So we see improvements in teacher ratings, particularly around disruptive classroom behavior. And then we also see improved functioning in peer settings. We see both improved positive interactions as well as a decrease in negative interactions. I mentioned earlier that the evidence base for behavior modification has largely been with children. Really, what we can say with certainty is that there is evidence that exists for the benefit of the use of behavior modification strategies, but that the age range that we're most certain about are the ages of 4 to 15. There are just fewer studies that exist for younger kids and then also for older kids. We see moderate to large effect sizes across treatments and across measures. So irrespective of what the DV is, the dependent variable, we see movement in the direction that we want when behavior modification treatment studies have been looked at. And these benefits are independent of comorbidity. So even if there is comorbid anxiety or even if there's comorbid conduct problems, we still see behavior modification having that positive effect. That being said, I want to be fair. Just because there is improvement does not mean that there's normalization. Oftentimes, there is still room for clinically meaningful improvement. So, said another way, these kids, even though they've shown improvement, oftentimes still are showing impairment in a variety of daily life activities, even after getting this kind of short-term acute treatment. So, it is not curative, it does not normalize, but definitely we see improvement. As I mentioned before, there are very few studies for the long-term benefits of behavior modification. And so we do want to be cautious with parents that this is not like put everything in for a short period of time and things are fine from now on, but really probably that we need to take this chronic care model. And that really the way that we are going to maintain any of the benefits that we see from these behavioral interventions is to continue to do them. That really we need to have this kind of sustained lower dose of maintenance even after we do this kind of big behavioral intervention. So we can't just do it and then walk away and have things be fine. We have to do it and then maintain it for those gains to maintain. I also want to talk about the impact of pharmacological interventions. And I think the evidence is pretty certain that it has a big and pronounced impact on a lot of important variables. But largely, these variables are aligned with the symptoms of ADHD. So we see things like improved ability to pay attention, decreased psychomotor, excuse me for that, activity. So decreased hyperactivity, decreased impulsivity. But notably, there are some really important variables like family problems, peer relationships, academic functioning, and academic achievement that are untouched by stimulant medications and even non-stimulant medications. Similar to some of these BMOD strategies, pharmacological interventions, when used alone, are rarely sufficient to bring kids into a kind of normalized range of functioning. We still see a lot of impairment with these kiddos. Another thing that's really important for families to know is that they only work for as long as the medication is taken. Time and time again, we have seen no residual impact of medication on functioning, even though that's kind of common lore in the psychological and medical community. There's no studies that back that up. So once medication is not taken any longer, any of the gains that we previously saw don't maintain. It's also really important to know that medication is not effective for all kids. And for some kids, potentially this unique group of individuals that have an intellectual disability and ADHD might be less responsive to medication or might have more side effects. So it's not an option for everybody. there's often poor compliance in long-term use. So we see some compliance in short-term use, but for kind of this notion of taking it for your whole life, particularly as adolescence is reached, we see less compliance with long-term use. Parents are often not satisfied with medication alone. But interestingly, the group that I was a part of did a series of studies looking at uptake of treatment. And one thing we found is that when someone starts first with behavioral interventions, they're more likely to use those behavioral interventions and even to be, even when they add in medication, they end up on a lower dose of medication in the long term. However, when they start first with medication, it really undermines the incentive and the adherence to any form of behavioral treatment. So, for example, behavior parent training. They started with medication first. They were significantly less likely to ever use that as a treatment modality than if they started with behavioral treatments first. Another point of information that is something to consider is that there are potential serious adverse effects in growth and substance use. Now, with the former, with substance use, that data is really controversial. And when I say controversial, meaning there are some studies that show no effect. So taking stimulants has no effect on long-term later substance use. There are studies that show yes, it has an effect. So someone who is taking medication in childhood has more of a likelihood of trying other substances later. And then there are studies that show less. So the data is kind of all over the place. But I don't think we can say fairly what the outcome is. And so we want to make sure we're giving that information to families to make a decision. The other thing is that for some folks, we see suppressed growth potential, meaning when they are taking medication in a long-term way, particularly stimulant medication, they can end up shorter than their growth potential would indicate that they should end up. And that's likely due to, over time, a lower caloric intake because stimulant medications do have the possibility of suppressing one's appetite. And so making sure that parents are aware of that and that they can, or caregivers are aware of that and they can put some accommodations in place is a really important thing as well. So if I were putting together the components of a really effective, comprehensive treatment package for ADHD, I want to mention what those components would be. One is I would always recommend that the caregiver, much of the time this is the parent, but that the caregiver receive a course of behavioral parent training, that they understand how behaviors maintain or increase or decrease over time. They understand how to introduce new skills, teach those skills, strengthen those skills, how to manage disruptive behavior, how to pay more attention to the good stuff that the kids are doing. Really kind of learning some of these basics can go a long way and have a tremendous impact both on parent reports of the kid behavior, but also on overall family functioning. I would always recommend behavioral school interventions, particularly when you're working with somebody who is younger. The earlier we can get in there and teach those same types of skills to teachers and have them implementing them in a way that helps to produce a warm and nurturing classroom environment that's skill focused, can go a long way for that kiddo. For many of our kids, though there's less kind of evidence for this, I would also probably recommend it for occupational therapy as well, and for when they're going into their careers, having that same type of support. As far as intensive behavioral client interventions, I call that one a use when needed. Interestingly, we see more, trying to think how to say this, like treatment mileage from intervening with the adults in the life of the client than we do with the client child, in particular themselves. That's not to say that it's not valuable to teach skills. Of course it is, and I'm going to talk about that later in more detail. But sometimes we live in a world where we have limited time with a family. We have kind of limited capacity to work with them. We have limited units of treatment that we can provide. And we just tend to see far more mileage in terms of behavioral parent training, behavioral school interventions than we do with behavioral client interventions directly. And that is likely a dose issue. When we're working with the client directly, oftentimes we need a far more intensive and sustained dose of treatment um, than we're able to get. And particularly, this intensive dose should be more aligned with like multiple hours per week of rehearsing skills as opposed to like a traditional outpatient model where you're only seeing the client for 1 or 2 hours a week. If we can get closer to that intensive client intervention, all the better. But again, we want to make sure we're using that as needed, not as kind of the default. Same thing with medication. Absolutely, when warranted, when needed, we should use it, but not look at it as the sole or first line intervention, that we're looking at behavioral interventions as first line and medication as supplemental, so using it when needed. Okay, so now that we've talked about what all of the components of a comprehensive treatment would include, I want to cover more broadly some key principles about how to deliver comprehensive treatment for ADHD. So again, I've said this in various ways, but I want to make sure it's landing. ADHD is a chronic condition, just as an intellectual disability is, and both require this kind of chronic disease model of care. Said another way, treatment doesn't stop. Treatment needs to be ongoing and adjust to the developmental and demand changes in the life of the person. The focus of treatment really should be on functional impairment and teaching adaptive skills to overcome any deficiencies that are there. And this is really more important than directly targeting any DSM symptoms of the disorder. And really, this focus on functional impairment, teaching adaptive skills is the focus of both assessment and treatment. The next point I want to mention, particularly as it relates to kids, which the vast majority of folks that we work with are, is that teaching skills to parents, to teachers, and to other adults in the life of the child is really the basis of treatment and what needs to be done first. You are going to get more impact by approaching treatment that way than approaching it solely trying to work with the kiddo alone. Medication is something that should be added if necessary, but we want to start with the smallest dose possible to try to minimize the impact of side effects and titrate up. And even though as mental health practitioners, oftentimes we are not in the role of making that decision, we can absolutely work with the medical providers in the life of the client to try to help to find an optimal dose that helps that person while also not putting them at risk for short or long-term side effects. To the extent that we can, integrating systems of care, so by systems of care, I mean mental health clinics, primary care, the families, the school system, all of these different systems that operate with and around the client really is something that we need to focus on. This should be a requirement of our type of care. The interventions that we need to do, we need to design so that they maximize the likelihood that they are useful, meaningful to families so that they can be done in the long run. Since these clients oftentimes need this chronic model of care, we need to design interventions first that people are willing to do outside of our office, and that's going to make a big impact. So this continuity of care is important, and sometimes that means maybe we start first with an intervention that's a little more easy to implement, but is going to be something that someone's able to do consistently. The last points are that early intervention is really important, and then that the intervention components we do need to be grounded in evidence. They need to have evidence of working with our clients. Okay, continuing on with some of these key points, I'm going to repeat some information about assessment, just in case that you watched the assessment portion of the video some time ago. So some things that are really important to keep in mind. First, you want to assess the client's functional impairment in all of their relevant domains. So home, school or work, with their peers. We don't want to assess only in a select group of domains, but really we're taking this integrative and kind of multifocal approach. The assessment should yield, meaning at the end you should have a list of target areas for treatment, and that these target areas should really be things that, if change, will continue to result in improvement in the client's functioning and have positive outcomes in their life. Oftentimes we have to prioritize what to start with, and we really recommend that the target behaviors that we start with and that we prioritize should be the behaviors that differentiate the child from other kind of non-impaired clients. So really these are the areas that are causing them the most impairment in their life, and that if addressed will result in the greatest change for them. And that these behaviors that are causing the client difficulties in their life most often are not the symptoms of ADHD, but rather are deficits in daily life functioning. And so by teaching these skills in an adaptive way, we're going to have the most impact on our client. The last point is that assessment does not end when treatment begins. Rather, assessment of treatment response should be ongoing. We should be doing continual progress monitoring and then determine if treatment needs to change or if we need to modify goals as clients are responding. But that assessment and treatment are these kind of, they feed each other, and they are both happening in this iterative, ongoing way. Okay, so big picture, I just kind of recapped for you this tremendous large literature on treatment for attention deficit hyperactivity disorder. What I'm going into next is for this particular group of people that have both ADHD and an intellectual disability. So what is evidence-based or evidence-informed treatment recommendations for this particular group? All right, so when we review the literature on treatments for intellectual disabilities and ADHD, overwhelmingly, there are 4 domains that we need to focus on that routinely and frequently come up as areas where we need to provide intervention in order to increase adaptive functioning skills or reduce impairment. So these 4 key domains are social, behavioral, academic, and focused on adaptive support. For purposes of this presentation, I'm going to focus on the first 2, social and behavioral. First, I'm going to cover social and really emphasize how to help someone develop appropriate peer interactions. And I'm going to cover both kind of what the ideal is and then what some modifications can be when the ideal can't be met. Second, I'm then going to cover behavioral. In addition to what I focus on today, which is how to develop and direct behavioral interventions, another thing that I want to mention is that I've posted some supplemental materials in your Canvas about how to do behavioral parent training. That series, that workshop is really important, but the length of it is beyond what we can cover in this video today. But I do want you to have access to it because it is really what should be considered a frontline intervention, a first choice intervention. And so I have kind of an expanded workshop series available for you. The remaining part of what we'll cover in the slides today with behavioral are things that can be done more in a traditional kind of social skills group, direct work with individual parents, or in kind of an outpatient model. All right, first with social interventions. Some things that I want to note or that are important for you to know. It is often very, very difficult for those with an ID, so with an intellectual disability, to engage conversationally with their peers. And part of this is because of the cognitive limitations that they experience. Sometimes age-appropriate topics are just beyond what their skill set will allow for, what their kind of developmental phase will allow for. Separate from that, those with ADHD, particularly those with the impulsive symptoms and with inattention, both of those can impact a child's ability or a client's ability to follow a conversation or provide meaningful input at appropriate times, so not blurting out or interrupting on others. And when you put both of those deficits together, this is not dissimilar from what I mentioned before about the double deficit, you can see both a struggle with topics as well as with social norms. This is important because with our work with clients, one of the things that we can help to intervene on are those social norms. Sometimes, I'm not saying always, but sometimes the topic and the maturity of the topic at hand um, might be beyond the scope of what we can do as mental health practitioners, and we may be better served to work with others who have a more kind of um, large role in the life of the child. So their teacher, for example, their parents can rehearse kind of more increasingly mature conversations, or may decide this is just not an area of intervention that's appropriate. But one thing as therapists that we can really do is help to develop those social norms to try to reduce that double deficit to more of a singular deficit. In addition to that, one thing that's really important, and I mentioned this when I was talking about ADHD, but this is also true within the ID population and looking at variables that influence outcome. But having a friend is really associated with subsequent decreases in severe behavioral dysregulation and problems, as well as increases in adaptive skill. When someone can develop even one reciprocal friendship, not only does that in and of itself provide a protective layer, but also increases the amount of practice that a person can do in how to have a meaningful friendship, how to so kind of it's just a naturally reinforcing situation that's going to allow someone to increase their adaptive skills through this rehearsal, this really kind of naturally reinforcing rehearsal, and then also decrease their more severe behaviors because they now have a mechanism for getting some of those needs met. So by intervening on these social norms, we are increasing the likelihood that a person can develop this kind of meaningful reciprocal friendship, which then has other positive sequelae that occur. All right, so within social interventions, I want to talk about kind of two large order goals. The first is helping your client to build appropriate peer relationships. And I want to put a little like asterisk on either side of appropriate and circle back to that in a moment. And then also how to understand and apply social conventions. So the skills I'm going to go through can probably be used for both, but for this first one, I'm going to really talk about building appropriate peer relationships. When I say this, I want us to be clear about who is an appropriate peer relationship. So a lot of times the clients that we work with an intellectual disability are not at the same developmental or maturational level as some of their same aged peers. However, they can still develop meaningful friendships, sometimes with different age peers, as well as sometimes differently abled folks. And so kind of the large order thing is determining who or what types of relationships are appropriate ones. Once that has been narrowed, then the method for how to do that is through direct skill building. With this group of folks, one of the strategies that has been consistently able to produce demonstrable skill gain in folks is direct instruction. By direct instruction, what I mean is explicitly telling the person what behavior they need to do or to desist doing, what behavior and how to do it, and how not to do it, tends to be more effective than what we call indirect instruction. Indirect instruction is more like when something naturally occurs or naturally happens, it's really reinforced, or sometimes circumstances are set up to try to increase the likelihood of a given behavior or skill being demonstrated, and then it can be rehearsed and practiced and reinforced, but it comes more from this what kind of unfolds organically. And for some kids and some clients, that can be great. But disproportionately with folks with ID, providing direct instruction for them and how to do this, along with the opportunity to rehearse and practice a lot, really seems to be a more fruitful approach for helping to develop skills and to gain and kind of increase the frequency of those skills being used. Another thing that I want to emphasize is that the greater the level of disability, the more intense and the more frequent the instruction should be. So you are going to be rehearsing, giving feedback, giving direct instruction far more than you typically would. And we shouldn't look at that as the increase in what we have to provide as being indicative of it not working. Rather, knowing and kind of accepting that it's going to be normative, that there's more kind of need for rehearsal, more need for practice, more need for feedback, more need for kind of direct instruction on how to do something as what is expected. And so then we kind of rise to meet that need of the client. Whenever possible, including caregivers or others in the life of the client is ideal because they're only with us for so many hours a week. And really, we're playing a numbers game here. When we need to deliver intense and frequent instruction, if we can only do that so many hours a week, then we really need to work with those who are in the life of the client more frequently to teach them how to do these skills. So routinely including things like parent-child homework or home tasks. So things like setting up the opportunity for the parent and the child to invite somebody else over for a play date, as an example, would be something that could be done for homework. And then really including as many adults in the life of the client as possible to provide effective and consistent and appropriate practice. Again, if I can emphasize anything here, it's direct instruction and increase the base rate for practice. I want to make one more point before I go on to the next slide, is that so often what happens with folks who have social skills deficits, whether we're talking about ID or not, but just folks that have social skills deficits, because their social skills are impaired, they are often excluded intentionally or unintentionally from social opportunities. So what can happen often is that over time, there's less and less opportunity for them to practice and get those naturally reinforcing or natural kind of consequences that can help shape their behavior. I'm going to use a different example to kind of send this home, but it's almost as if, like, let's say you had a child who couldn't really read very well. And so in class, instead of calling upon that child, the teacher calls on other kids who are skilled readers. Well, those skills readers get more and more rehearsals at reading. The less skilled reader gets less and fewer opportunities to practice reading. Or they do things like they pair up kids and have the more skilled reader read for the less skilled reader. Again, it's a very well-intentioned strategy, but in the accumulation, there's less and less opportunity for the less skilled reader to actually read, to sound things out, to have effective rehearsal. Same type of thing with kids who have social skills impairments. There are often times when they do something disruptive or frustrating to other kids or pulled from social groups. They might sit alone at a desk at the back of the room. They're pulled from the cafeteria and are sent to another area of the cafeteria where they're more isolated. Not only is that problematic in and of itself for some obvious reasons, but another thing is they lose that opportunity to practice. Oftentimes when clients struggle, again, with social skills and understanding how to initiate peer relationships, parents will step in and do it for them, or caregivers will step in and do it for them. They'll speak for them. They'll say, I think what you meant is this. Each time they're doing that, they're taking that natural learning opportunity away from the child. And as mental health therapists, we want to be thinking in the opposite direction. How do we make more and more and more opportunities for the client to practice? And then not only practice, but set them up for successful practice. Here's what I want you to do. Now I want you to do it. Man, you just did it. That was fantastic. Let's keep doing it. Oh, you did it again. I'm super proud of you. You're getting it. You're getting it. Giving them all of this saturated practice of how to do these skills in a way that is more likely to increase the likelihood of them getting a friend and keeping that friend. Okay, on to another goal of social interventions, which is to understand social conventions. How do we do this? By really skill building. So one of the very first things we have to do is identify what are the skills that are impaired or lacking. So these could be, very basic social skills, things like how to enter into a conversation without interrupting, how to take turns, how to share. Most typically developing kids kind of organically pick these up, but for folks with an intellectual disability, they oftentimes, again, with this direct instruction, they really need it explicitly taught to them. There's also the need for significant practice and repetition, as we talked about before in the previous slide. A couple other elements, though, that I want to bring up to you and explain to you is that there's three other pieces of information that can be really, really helpful with this like understanding and then being able to apply social conventions. So the first is modeling. It seems like an obvious thing to say, but if our clients aren't kind of naturally, organically picking this up from just, you know, being around other kids, it's not likely that they're going to be able to generate the skill on their own. And so, kind of first modeling for them, this is how you take turns. Or first it's my turn, now I go, but you don't. Then it's your turn. Now you go, but I don't. Now it's my turn, and then seeing if they can kind of realize that it's not their turn yet. Now it's your turn. And then kind of just getting into a rhythm. I did a very quick, very few repetitions, but you'd actually do that, you know, in a highly repetitive way. But showing them what to do is very, very helpful instead of trying to get them to generate what to do on their own. The second is role playing and making it really clear we're role playing a positive example right now versus we're role playing what not to do or a negative example right now. And you can do both kind of pro-social and anti-social role plays, but you want to have more role plays, more kind of contrived role plays using appropriate application of the skill than inappropriate application. And then last, I mentioned this a little bit, but really having a very high level of performance feedback with more weight and emphasis given towards catching them doing the right thing. I know in previous workshops you learned about errorless learning and how that concept can really help someone to acquire skills. Same concept here. So giving a lot of performance feedback as quickly and as soon after the behavior as possible to let them know what they're doing well, what you want to see more of. And then you can still give some corrective feedback. Now let's try it this way, or now let's add this part and we're going to try it and practice it again. But getting that feedback can be really, really meaningful to clients. And just as I said before, I want to emphasize this so much. Practice, 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 practice more than you ever think that you probably would is so, so helpful. And getting other caregivers and professionals on board to allow these skills to be reacted to consistently, effectively, and appropriately when they are practiced can only be to the benefit of the client. All right, now we're moving into behavioral interventions. I think it would be fair at this point if you're saying, well, in some ways aren't social interventions like the very skills that you're teaching actually behaviors? And I would say, yes, absolutely. And I'm so glad that you realize that. So there's not a tremendous amount of distinction between behavioral interventions and social interventions. A lot of these components are the same: modeling, rehearsal, role playing, performance feedback, breaking things into their components, and the same is true with behavioral interventions. When I say behavioral interventions, really what I mean is things that are not explicitly social, but might be broader than that. And really big picture, what I mean are behaviors that will help to improve a person's adaptive functioning or daily living skills, as well as decrease any problematic or maladaptive behavior that they're showing. So there are some ways of doing this. One I know you talked about in your first lecture, again with Jeff, which is reinforcement, or how to increase or apply a consequence that will increase the likelihood of a behavior happening again. Another is something called a daily report card. Again, for this particular lecture, it's a little outside the scope because I know we're getting really, really long with information already, but another tool that I linked for you on your Canvas is a how-to workbook for setting up a daily report card, and then also how to monitor it and modify it over time. And so I want you to feel completely, able to use that and distribute that if it's helpful to you. And also reach out to me if you ever have questions about daily report cards. Token economies are when you're strategically applying a consequence like a punishment and a consequence like a reinforcer when certain behaviors happen. And then you link those to being able to get preferred rewards. But I think what would be most helpful at this point is to really talk through some key and big principles about behavioral interventions. And you can, as you're hearing these principles, think through some of the stuff we've talked about already, but also how you could use this to apply to new interventions that you develop. And then when we all have the opportunity to meet together, we'll actually work on designing some of these. Okay, so some general things to keep in mind about designing and implementing any behavioral interventions. The first is before we design, we have to assess. And so after these kind of general areas of impairment are assessed or identified within the assessment, we really, as soon as possible, want to drill down to those specific target behaviors that are identified as being relevant for each domain. So the sooner we can go from broad problems to specific behaviors, the more kind of clear and almost like builds itself the behavioral interventions will become. If you recall from the assessment portion of this, that ABC form that I walked through is a really useful tool for drilling down to some of those target behaviors. The target behaviors should also be defined in really precise operational terms so that you and anybody else that's doing the intervention, and particularly the client themselves, understand exactly what we're talking about. We then want to identify those antecedent conditions and then what are the consequences that are controlling that target behavior right now. Remember, if a target behavior is happening, it's because something in the environment is maintaining it. What could be maintaining it could be like the lack of knowing what else to do. And so the intervention then becomes we got to teach a different skill, or it could be it's being unintentionally reinforced. And a lot of times this is the case. So like I keep doing this behavior because it gets me out of something that I don't want to do. I keep doing this behavior because it gets me access to something that I want. I keep doing this behavior because it gets me attention. And when even in that example, it implies that there's like some purposefulness. A lot of times this is happening beyond like conscious control. People don't really realize it. But if things are happening and continue to happen, there's always a reason for it. When we find that reason, then we either change the consequence or we teach a new behavior or the combination of both. So understanding these relevant antecedents, behaviors, and consequences are really, really important. The more we can directly observe this, the better, but sometimes that's just not a reality, and so we have to rely on report from others. But it gives us this information. We start to understand how these ABCs, these antecedents, behaviors, and consequences are meaningfully linked. And it also gives us information about like the severity and frequency of it. So we can say, well, then how do we develop an intervention to match in intensity or severity? Okay, so last but not least, some other things to think about generally with behavioral interventions. Treatment involves establishing interventions in which both the antecedents and consequences are modified in order to affect or change these target behaviors. The response is then continuously monitored and the intervention itself is modified when either it's no longer needed or it's not working well enough. And I mentioned some of these in the previous slide, but I want to make sure I go over all four again. So we have avoid or escape as a possible maintaining consequence, attention or connection with somebody else as a possible maintaining consequence, access to something or access to an outcome, and then lastly, what we call automatic because it feels good. So something like sensory stimulation. These are all reasons why a behavior could be occurring and continue to occur. And these are the consequences that we are looking to modify in order to change the behavior. Or if we think that somebody doesn't know what else to do, we modify the antecedent, we teach them how to do something differently and do that in place of by adding one of these consequences in. I know I'm talking in a really like high level way, and that can be annoying when you're thinking about like how do I apply this specifically? But that's really when we finally connect in a live way. What we're going to be working on is how do we actually develop and produce one of these behavioral interventions. So I'm really excited to get to the point where we can actually connect on that and practice and rehearse it together. Until then, I hope you've learned a lot of information, and feel free to reach out to me if you have any questions at all.